So it is my pleasure to introduce Dr. Kelleher. He's a distinguished professor of pediatrics and public health and chair for innovation in the pediatric practice in the colleges of medicine and public health at the Ohio State University. He's also vice president of community health and services research at Nationwide Children's Hospital in Columbus, Ohio. He is a pediatrician and health services researcher focused on improving and measuring the quality of pediatric care for children affected by the social determinants of health, violence, neglect, alcohol, drug, and mental health disorders. He has been continuously funded by NIH and other federal agencies almost since he completed his training in 1990. He is involved in strategy development for the Nationwide Children's Healthy Neighborhood, Healthy Family Zone, focusing on neighborhood leaders, community agencies, and related partnerships to improve housing, employment, schools, and safety on the south side of Columbus. What I love about Kelly and his work is that he sees the residents and the partners in the south side of Columbus as his friends, his inspiration, and co-producers of the work. And this area of work that he's doing has become integral, central to Kelly and also his family, and they try to live those changes themselves. I actually met Kelly at the National Academy of Medicine, where he had worked in a number of very important projects, including the 2009 Adolescent Health Report, that it was called Missed Opportunity, because with adolescents, there's so much more that we can do, and it can have such an impact. And he's also involved in a forum about child well-being and mental health, and he's bringing really innovative ideas and tools to that work. So I present to you Dr. Kelleher.
Thank you. Thank you, Dr. Diaz. And a few interesting things. Number one, 50 years. Congratulations to Dr. Friedman, Dr. Morrison, Dr. Charney for this wonderful conference. And 50 years used to seem like a really long time to me, but it's not as long as it feels. But this is the group that survived to the last talk. So congratulations to all of you. I realize I'm the last thing between you and dinner or your next appointment, so I want to make this worth your while. But before I start, I want to give you the take-home message, because I think that's really the important thing. Dr. Diaz was inspirational to me 12 and 15 years ago, because in their clinic, in their wonderful adolescent program here, they bridged the community to clinic gap for adolescents. They brought the clinic to the community, and they brought the community to the clinic, so that adolescents really felt part of the services. And that was the first big innovation for me. The next big innovation, though, and the one I want to talk about, is the neighborhood itself as the patient. I'm a pediatrician by training, and like some people here, I've practiced for 20 years, and I got tired of putting bandages on children in the midst of a hurricane. And their lives on the south side of Columbus were chaotic. It was one of the areas worst affected by the housing foreclosure crisis, violence, homelessness, drug addiction, infant mortality, and I'm offering a little bit of amoxicillin for ear infections. And it was unacceptable. So the neighborhood as patient is, I think, where we see our future. So let's see if I can do this. First of all, I have some disclosures. These are grants that I have. Unfortunately, none of them are from big commercial companies with a lot of money. But I want to address three things. First of all, our broken paradigm. Secondly, innovation and goals. How do we move from providing health care to population health to actually community well-being? And secondly, what's the role of the healthcare provider from a passive observer of the neighborhood and community to treating the neighborhood as patient to actually being partner and part of the neighborhood? So I want to tell you a little story because for all my friends in New York, Columbus is a flyover place. And so Columbus could be in Idaho or Iowa or one of those O and IO states and in the middle. But Columbus is an interesting place, to be honest with you. It's number one in the Midwest for population growth, number one for job growth, wage growth. It won the Intelligent Community of the Year nationwide in 2015. It's also got a whole bunch of other awards from different magazines and national organizations. The economy is exploding. Unemployment is almost non-existent. And in the middle of all that, the board of the Children's Hospital there, Nationwide Children's Hospital, said, we want the best outcomes in the world for our kids. So we built, by most measures, according to the Children's Hospital Association, the largest children's hospital in the United States with 12,000 plus employees, a super number of beds, lots of NICUs. It's one of the safest hospitals in pediatrics, rated every year in the top 3 for safety events, and specialty outcomes always in the top 10. But they said, you know, how are we doing on wellness and population health? So we built an accountable care organization called Partners for Kids. Full risk capitation. We accept a full amount, a fixed amount every month for every one of 330,000 children in these 34 counties. And that full financial risk comes through 5 Medicaid managed care plans. No providers in this area have prior authorization. They don't have denials because we manage them through guidelines and through profiling and through improving their practices. And this is the funds flow that inspires some population health initiatives. It's from the Ohio Department of Medicaid to all the pediatric Medicaid managed care plans, of which there are 5. They all subcontract to Partners for Kids. We pay all the medical providers, and then we get to reinvest any savings into child health programs. And that flexibility in funding is precisely what Dr. Blumenthal talked about, is where is the flexible funds, where are they going to come from? So we can show that we've reduced emergency room visits, we've reduced inpatient stays, and this is through the use of 100 care coordinators, nurses, social workers, and bachelor's level care coordinators that work in teams. We can show that we can drive down the costs of medical care through complex patients. The number of days per 100, I probably have a wonderful pointer here. I do. Yes, it shows up. But basically, this is a run chart using the number of patient days per 100 feeding tube patients. So for all of our neurologically impaired feeding tube patients, we can show over time that we drive down the actual number of inpatient days per patient, and this has continued to this day, and now we're doing it for epilepsy and trach patients and other patients. But the board looked and said, well, Kelly, you know, good job with all that. That was wonderful. And we have the best outcomes in the world for certain surgical conditions, medical specialty conditions, genetic conditions, but community outcomes are terrible. Our rate of suicide, our rate of infant mortality, our rate of behavioral health problems, our asthma admission rate, they're all still terrible. You know, do we need to build more hospitals? Do we need to build more clinics? What do we need to do? Our maternal mortality even is going up. And it turns out that when you profile where these things happen, there are 8 neighborhoods across the city that account for about 1/5 of the population, a little less than that actually. But these neighborhoods account for 50% of all the gun violence against children in the region. They account for 1/3 of all the infant mortality, half of all the maternal mortality. They account for about 1/3 of all the suicide attempts. So their rates across the board are much, much higher. Moreover, if you look at this lovely community of Upper Arlington, which is the largest location of faculty members at The Ohio State University teaching there, including many of my colleagues, this area here is one of the highest income areas in the country and happens to have almost the lowest infant mortality in the entire United States. And right across the river here in Franklinton, you have the lowest life expectancy rate in the state of Ohio, separated by a river. And so Franklinton there, which is the negative area that I told you about, their life expectancy is 25 years lower than Arlington's. So there is no medical treatment, there is no intervention, there is no clinic, there's nothing we can do in the medical situation that can control for that kind of neighborhood influence. So as long as we refuse to acknowledge the importance of the neighborhood and the community on what happens to children and families and eventually chronic illness and high-cost elderly patients, we will fail as a medical system. We will fail, depending on what your goals are. If your goals are to provide good care in your clinic, you can do a great job. If your goal is to improve the health of your population, not so much. So this is the population of the neighborhood right across the street from the largest glass and steel, beautiful, pediatric children's hospital in the United States. This population is 2,000 people, 612 children. It's called Southern Orchards neighborhood. It's 3/4 minority. The per capita income is $17,000 compared to the metropolitan average income of $52,000. Only less than 1/4 of the units are owner-occupied. It's about 500 families. I would show you the school data, but it's a failing school. It's the 3rd lowest ranked school in the state of Ohio. It's a failing neighborhood that had 8 years ago, 30% of all the houses unoccupied, vacant. Now, they were occupied, but they were occupied by people dealing drugs, squatting, homeless, et cetera. So it was a dangerous neighborhood, and people with children preferred not to live there. So the hospital said, what are you going to do about this? What can we do? We have one of the wealthiest hospitals in the country. The children's hospitals in the United States, the top 10 children's hospitals, and you guys are affiliated with CHOP, and I include them in that information, and have on average endowments exceeding $1 billion in reserves. The revenue of Nationwide Children's Hospital per year is $2 billion, 12,000 full-time equivalent employees. That is big business, no matter how you slice it. And so, looking across the street at a neighborhood that's got a lot of foreclosures, bankruptcies, violence, lack of employment, and one of the highest infant mortality rates in the state, what do? Well, we've learned a lot in the past 10 years, and the National Academy of Medicine summarized a lot of this in many of their models. We know that children at their center have biology that's surrounded by individual determinants, social determinants, the built environment, the national environment. The thing that's exploded in the last 2 years, though, is the fact that the community or immediate neighborhood surrounding the child is one of the best predictors of all the positive and negative outcomes we know. And that amount of literature, and so when we looked at what was happening in our community, we said it's actually neighborhood effects that have to be addressed. And so what do we do when we're trying to address the genome and the biome? It's actually what's called the exposome, or the environment the child's living in, that we have to address more effectively. So the board, along with the mayor's office, United Way, and some community agencies, came together and said, we need to build something different. And it has to be collaborative because it has to be across sectors. No one can do this alone. But certainly, the hospital can play a leadership role, a programmatic role, a measurement role, and an initial money down to start this. And so we built what's called Healthy Neighborhood, Healthy Families, using the mayor's office as a launch pad, using the neighborhood agencies as our community quarterbacks, and overall, using the hospital as an organizing principle. And these were the 5 prongs. It was education, safety, health and wellness, workforce development, and affordable housing. And we didn't know where to start, but we asked the neighborhood, where should we start? And overwhelmingly, the story was of a loss of community and blight that was affecting the neighborhood with these abandoned households. So today, I just want to tell you about one of these prongs, and I'm going to talk about the housing prong in a way that I hope is different for you. If we have time in any questions, we can talk about some of the others. But we laid out 4 phases of housing development with our partners, the Mayor's Office of Development, and a community development organization called Healthy Homes, and our program. And the first phase was to provide grants to stabilize existing homes. The second was to build or rebuild homes that had been destroyed. The third was to start to offer jobs through a low-income housing tax credit, and I'll tell you about that in a minute. And the last is to make sure that there's affordable rentals available, because as you know, the nation has a shortage in affordable rentals for families. So these were the first grants we provided. We provided over 150 homeowner stabilization loans. These are loans to improve the properties of people who already live in the neighborhood, to improve safety, lighting, exterior appearances, and try to clean up with the neighborhood, because it's a very characteristic neighborhood and has a certain landscape and architecture to it. And immediately behind that, we went in and did 350 rebuilds. And some of these are ground up, tear down the old thing if it's completely lost, salvation. But when you have vacant lots and empty spaces in neighborhoods, it's not safe for children to walk to school. And we built these from the school out so that as the neighborhood grew, people would be more attracted to bring young families into the neighborhood. And you have to do 3 to 4 houses on each block in order to have enough of an influence, because many mayor's programs sprinkle houses all around, try to get as many neighborhoods involved as possible. But when you put a single house on a block with 6 abandoned homes, you do not have the effect you need. So we're actually looking for what's called a neighborhood effect. Can we change the whole quality of the neighborhood? The next project is something that I don't think enough healthcare institutions take advantage of. Low-income housing tax credits are present in every state, and these are tax credits purchased by investors to offset their tax burden. And these tax credits work in such that a private developer who's going to pay way too much on profit taxes says they need a break on their taxes, and they can reduce their tax burden by building low-income housing. But if they have partners who can provide the programming to get those competitive tax credits, it's an outstanding thing. So we have now partnered on 3 low-income housing tax credit deals at a minor cost to ourselves. So we provide the training, sometimes we provide the land, sometimes we provide some jobs for people that live there. But overall, this particular Residency Career Gateway program is now training 60 families to work at the hospital, where we have needs. We have 600 jobs posted as of today. And we're training those people at this Residency Career Gateway because there's a career center on site for the local community college. They walk to the hospital for internships, and then they take employment there. And in the process, it was a $15 million building that got put up in a very high-risk neighborhood almost right next to the hospital. So it's a win for the mayor, it's a win for the community college, it's a win for the developer, and it's a win for the hospital. This is the most recent deal that we closed in July. This is a $20 million housing stack for 170 low-income affordable apartments for families, because a strange thing happened. After 8 years of working on all the housing projects, suddenly the neighborhood started to flip, and market investors came in and started pouring money into the neighborhood. Well, then what suddenly happened was people with very minimum or low-income jobs, minimum wage jobs, who work at the hospital said, we can't afford to live near the hospital anymore and walk because the rents are starting to go up. So we decided that we have to own 15% of the rental properties within the Southern Orchards neighborhood to help manage the rents and keep them affordable for our workers and the other workers in the community that need affordable help. Interestingly, the top tranche, so this is what I went to medical school for, to learn about mortgage debts on low-income housing loans. But the bottom line is, the very top group here is a set of commercial banks. And they have community reinvestment dollars they have to spend. And normally they write those off as a loss because they have trouble spending their money in high-risk communities on small grants at a time. But instead, we come to them and say, if you pool your funds into this risk, we will guarantee the loan. So the hospital, through its long-term reserves, guarantees the loan. The banks have no loan drop risk, and they only have to sign one deal to spend a large amount of their community reinvestment dollars and meet their federal obligations. So helping the banks is part of this, getting money from the Affordable Housing Trust of Columbus, because they're trying to expand what they do, and then the remaining money from the Ohio Capital Corporation, which is the CDFI, the Community Development Finance Institution, from the Treasury Department, rounds out the deal, and the hospital underwrites, guarantees the loan, and builds the properties, and these will all become equity holders in 170 units that will appreciate over time. So once you have a track record, then finance comes from the community into these deals, and as you see in this deal, if we pull it off right, and we deliver the properties, and they appreciate as we expect they will, the hospital has invested $0 in 170 units that are going to be built around the hospital to improve the neighborhood and help our workers. So finance deals are possible if you're in the room, and there's a white coat phenomenon. So should healthcare institutions be responsible? Dr. Morrison asked. Well, frankly, when you walk in the room with the white coat on and the bankers are trying to decide whether to do this deal, they all stand up and say, oh, the doctor's here, let's get a seat for him. And, you know, I know nothing about mortgages, but yet there's a white coat phenomenon. We have political capital that we're not using. And I think we can use that in the boardrooms to make deals happen if they're good deals for people. Well, Fannie Mae, the mortgage company, said, hey, this is pretty creative. We like how the hospital's partnering with this, but we think it's not enough to have housing deals that are isolated from workforce deals, so we'd like to fund a pilot workforce training. And so our community development organization called Community Development for All People, which is a church-based, faith-based, not-for-profit group that's been in the neighborhood for 25 years, they recruit families. Goodwill Industries does job training for hospital-relevant jobs that we have posted in large numbers. We provide the internships at the hospital, and then we hire about a third to a half of those people coming through using Fannie Mae money to initiate the training from Goodwill and CD4AP. So people want to ride on a winner's coattails once you get the ball rolling. And so having early successes is really important, and this builds on a Department of Labor grant that hired 6 interns to work in our informatics department from Goodwill Industries. So we have partners already. All of you work with Goodwill or know of Goodwill places. We all know of our community social work agencies, and it's really bringing those people together to solve our hiring needs, our space needs, and our environmental needs in the community. So far to date, we have $41 million in the housing completed, $22 million that's already under construction. There's another $20 million more in negotiations we expect to close by the end of the year. And in February, we'll be applying for $15 million more in LIHTC deals. And this is all for 2 zip codes on the south side of Columbus. So the dollars are there in the housing industry, in the healthcare industry, and in the employment training world. We don't need new dollars, but we need to align our dollars with the others. And what does that get us? Well, you'll see that in 2009, when we started our housing program, we had a vacancy rate on the street at that point that was 26.9%. And that's compared to the community average, which was around 11% at that time. But as you can see, the vacancy rate now in the HNHF impact area is down below 6%, and we've actually had to expand to 7 more census tracts because market rates now are driving up the costs, and we're sticking with just affordable home purchases in our original target area. But it's not enough to say that we're reducing vacancy rates. Does it help people? Do people want to live here more? And so we are surveying 300 people a year over the past 3 years. We'll be doing that for at least 3 more years. We have funding for that amount of time, 6-year surveys. These were people randomly collected door to door on a census tracts. And what you'll see is over every measure we've collected, whether I like being a member of this neighborhood, whether I feel like I belong, whether the neighborhood's a positive influence, community spirit's going up, is there good changes happening, I like to live here. By every measure we collect, the measures are getting better over the 3 years that we've been collecting. Now, just having parents say that's a good thing, it's not enough. the accountants and the business people, since we're capitated for care, said, you know, Kelly, this was the most expensive neighborhood we had in the area. And even though our employees like walking through it now because it's much, much nicer, are you actually saving money for our health plan? And so we looked at the emergency room visits compared to a comparable neighborhood called Northeast. And we looked at the inpatient days. And Northeast is here, the hospital's here, and the South Side's here. The South Side's in blue. And what you'll see is over the past 8 years, that inpatient or ED visits went up 10% in our neighborhood, but went up close to 80% in the comparison neighborhood. And inpatient days went up half as much in the South Side compared to the Northeast neighborhood. That was the original comparator. Now, we'll be doing several more analyses with 2 neighborhoods in Cleveland and 2 neighborhoods in Cincinnati to see if these results stand up. But right now, the accountants are thrilled and actually do believe we've had a lowering of costs relative to other neighborhoods through this activity. We invested a lot of money in housing. We got a lot of partners involved through it. And in the process, we saved some money on our health plan and have changed the walkability of our neighborhood dramatically. But there's also been, besides being an innovation and investment by the hospital, it's also been an innovation in our relationship with the neighborhood. And for decades, we were near the neighborhood. We were across the street from the neighborhood. We were not involved in the neighborhood. But then, for a while, we began to treat the neighborhood as a patient more formally, and we said, okay, we're here now to rescue you. We're here to serve you. We're going to do school-based programs. We're going to do outreach clinics. We're going to stick our van out here, in the mobile van out here a couple of days a week, and all that will help your children get better. That was okay. But then we went to the hospital for the neighborhood, where we were actually committed to the goals the neighborhood had. And finally, we're beginning to be a partner with the neighborhood, first with the neighborhood, but now as part of the neighborhood. And I just want to explain what those are. So passive, we were near the neighborhood. We did a ton of expansion. As I said, we became the largest children's hospital in the country. A lot of eminent domain. We have a lot of parking lots, took over parking garages everywhere. The neighborhood changed dramatically, and not always to the best for the neighbors. But when we started to think of the neighborhood as a patient, we began to do school clinics, safe sleep campaign. But then we shifted to hospital for the neighborhood, housing stabilization. We began to hire people in the community. We've now hired 1,000 people from the neighborhood over the past 5 years. We have drive-through program. We closed. There's a liquor drive-through store in the middle of the neighborhood and an adult bookstore. We bought both of those properties and closed those businesses, which cost 12 jobs for the neighborhood, but actually they were a nidus for a lot of crime and other activities that was going on. And we've been moving into partner with the neighborhood. So community fairs, we have regular job training and job fairs in the neighborhood now. We, in the drive-through stand I mentioned, it's now a drive-through produce store for the Mid-Ohio Food Bank. So people can drive through and pick up their produce or sit at the restaurant and have food there. And finally, this is where we've actually moved to the hospital as neighborhood, where our employees have actually changed. And that's been the most rewarding part for me in some ways. We now have neighborhood incentives for people to buy houses in the neighborhood, where our employees can buy the houses. The bicycle cooperative that was started in the neighborhood is 3 of the board members and several of our employees routinely run the bike collection program for the bicycle co-op to give away bicycles for children and adults in the neighborhood. We run an Experience of Poverty program every year, and we're now up to 2,200 of our employees that have been through the Experience of Poverty, and it is the #1 requested training that we offer at the hospital. We've had a series of racism roundtables in the neighborhood to talk about how racism is affecting people. And we run a neighborhood leadership academy because we realize it's not enough for us to change. Our neighbors want to participate more proactively, and they need to know, what's a 501c3? How do I write a grant? What's a meeting agenda look like? What are you talking about quality improvement? How does that work? So we run 15 people every year through the Neighborhood Leadership Academy run by the Central Ohio United Way, and that's been an outstanding success and really provided more leadership for us to include in our committees. And then finally, our mentoring program with our own staff to volunteer at the 2 local schools. And basically, this has been the growth in our mentoring program over the past 3 years, from 55 to 150 to 230. I mean, every year, more and more of our staff want to participate in mentoring local students. So it hasn't just changed the neighborhood, it's changed who we are as a healthcare organization. And I think that's the innovation that I think will be the most sustainable over time. So are there challenges to caring for the community like this? It's really hard to measure outcomes. There's a lot of things, and when do you start, and when do you finish, and who do you compare to? You know, our anchor institutions don't have these skills. We actually are very good at acquiring land and selling property and moving things around, but we're not so good on the residential side, and we have to learn those things. Spread, how do you spread these kind of things? Children's hospitals have a unique mission, but frankly, this has been more about the politics locally and the financing locally than anything to do with real return on investment. And then financing, learning about all the different financing tools and really taking risk for the population, because it's only when you show long-term savings to the accountants, not short-term, doesn't need to be a lot, but it needs to be a little bit and long-term to really stick in the minds of the CFO as they're going forward with the board. So do we have evolution in our goals and innovation? Yes, and at Nationwide Children's we've moved from healthcare to initially population health through our ACO, and now I think we've come full circle all the way around to community well-being. Our CEO even does the mentoring in the grade school. He's not very good at it yet, but he's learning, so it's been a real eye-opener. And there's also been an innovation in who we are, an evolution in who we are, from passive observer of the neighborhood to neighborhood as patient to neighborhood as partner, and now to us being part of the neighborhood. And that's really where our story is right now. We're excited to share it because we really feel like it's changed us as much as it's changed the neighborhood. But we see long-term hopes for changing healthcare outcomes for kids and families. Thank you.